Mitral stenosis, progressive dyspnea and exertion, non-specific for any valvular heart disease. Hemoptysis, why? Why? Why are we seeing this more so than any other valvular heart disease? It's the fact that the left atrium is not emptying and back up into your pulmonary veins, hence resulting in, could you have increased RBCs in your lungs and such? Sure. Coughing up of blood, that is not good. Heart failure, late finding, once again, a bad prognosis. It means what? Well, the opening snap, we talked about how it'll be after S2, called this a mid-diastolic murmur. The closer that your opening snap is to S2, the worse is the prognosis. Tell me the size of your left ventricle, very, very tiny. Eventually, what's going to happen? You back up to pulmonary edema? Sure. We talked about that, increased hydrostatic pressure, right? Then you have what? You may transmit this disease into the right ventricle. Might have right ventricular failure. Is this, very important question, pay attention. Is this cor pulmonale? Nope. But Dr. Raj, right ventricular failure secondary to left-sided heart failure? Yes. That's not cor pulmonale? No. So what is cor pulmonale? It is right ventricular failure secondary to a primary pulmonary disease, such as maybe pneumonia, maybe pulmonary fibrosis, so on and so forth. But when you have right ventricular failure here due to left-sided heart failure, that's not cor pulmonale. But if you do find it, mitral stenosis, not good prognosis. Physical examination, palpation, right ventricular heave. What does that mean? It means pulmonary hypertension. What about the PMI? Pay attention here. What is PMI? Point of maximal impulse. So I don't know what that means. Yeah, you do. PMI is the apex of the heart. And where's the apex? What chamber is that when you refer to the apex? Left ventricle. What's the size of my left ventricle? Either normal or maybe decreased. It's never cardiomegaly. That makes no sense. The left ventricle is not going to go laterally displaced. Is that clear? Every single statement that we have here has huge clinical relevance. I have information that goes outside of the apparent slides and such, but that's only so that we have a complete story, so that we have more differentials, so that we integrate more material. All this information at some point in time is touched, will be touched, and forever will be part of your understanding. Mid-diastolic murmur is what we talked about, occurs during diastole. Heard loudest, well, we talked about this where, and when it comes to mitral issues. Where am I? Where are you upon cardiac auscultation? Here's let up, that up, let up, that up. So that's let up, that up. No issues between S1 and S2. So it's not let up, that up. That'd be holosystolic. That's not what this is. It's after S2. You have an opening snap, and then you have. It's after S2. It's after that that up. You're going to hear an opening snap. Where are you going to hear this? Auscultation, fifth intercostal space, mid-clavicular. Apex is where you are. What kind of murmur? A mid-diastolic murmur. AFib is something that you want to worry about. What does AFib mean to you? It means that you're going to mess up your conduction system, all right? And with atrial fibrillation, what might you be looking for? What wave are you paying attention to? You tell me. Atria. If you say QRS complex, I will find a way to come out there and slap you. No, I won't. But the P wave is what you're paying attention to. Atria, right? And what's wrong with those? What's wrong with those P waves? They're not present, or they're wavy. Okay? Now sawtooth. That's atrial flutter. That's another discussion for another day. Atrial fibrillation is wavy P waves. Okay? You don't have them. Now, what are you worried about with AFib, please? Well, you've heard of Virchow's triad, haven't you? Virchow's triad. Not Virchow node, Virchow triad. I drew a triangle there because it's 3 different points. One point would be endothelial injury. Is that what this is? No. Number 2, hypercoagulability. Is that what this is? No. Number 3, turbulent blood flow stasis. Yeah, this is turbulence. So what does Virchow triad mean to you? The development of what? A thrombus. And so therefore, if a patient has AFib, aren't you prone to thrombi? Absolutely. And as soon as you hear AFib, what are you putting this patient on immediately as prophylaxis? Prophylaxis for what? Atrial fibrillation in form of thromb. Going crazy in here. And then what? And then you break it off. You break off an emboli. Where does it go? It could go maybe up in the carotid. That is the most devastating manifestation. Going up in the carotid, resulting in a cerebrovascular accident. Why would you want a stroke? Prevent it from happening. The drug, by research, shown to be the best for prophylaxis of thrombi formation, AFib, is going to be warfarin. You wage war against the thrombi for prophylaxis in atrial fibrillation. Let's continue.